Thanks, Charnel. And yes, thanks everyone for joining. It's a real pleasure to speak with you today from snowy Salt Lake City. Actually, we just got some good snow starting up today. I first off wanted to acknowledge the land that I work and recreate on here in the Salt Lake Valley is the ancestral and traditional homelands of the Shoshone, Paiute, Goshute, and Ute tribes. And I do recognize the relationships between tribes, tribal nations, and the government. I have no conflicts to share, and just a little bit more about myself and my work to help introduce this topic and where the viewpoints that I am able to share where I come from. So, my work here at the University of Utah, I'm an assistant professor in the College of Nursing, and I'm dual trained as a clinician scientist. I've provided acupuncture therapy and Chinese herbal medicine for almost 25 years. And my time here at the University of Utah, as well as my doctoral PhD studies, I've focused on the menopausal transition. And I have to say, when I started my studies in my mid to late 30s, I didn't know what I was getting into, but I'm really glad I did because now that I've aged into my demographic, I can see quite certainly why this is such an important topic for everyone with either has or has had a uterus. So this very busy slide shows you three interventions. It's actually Menogap at the top left. It was and is an intervention we've designed to fill a gap in menopausal care. It's a billable group medical visit. So anyone on the call here who's a prescribing provider, I encourage you, if you get excited about this topic and want to help as many women as you can, think about the group medical visit. Very briefly, it's billable. It's the same medical code as a one-on-one visit, the 99211 through 15, if it's a return office call. You just need to room people as usual. It can be online, it can be in person. The medical care you can deliver during that visit, as well as the social support women give one another, it's amazing. It's really been life-changing. Menogap was developed with a an advisory board of midlife women, many of whom said, "Hey, in my community, women aren't insured, or in my community, we need interventions in Spanish, for example." So we've adapted Menogap. On the top right is Waning Moon. We've adapted it with and for Indigenous women. It's really a lot of fun. That's a nurse-delivered intervention, no longer a billable group medical visit, but it's care delivered by an RN, and then she provides in-house referrals at the Urban Indian Center of Salt Lake. And then bottom left, we've adapted Menogap with and for Hispanic women. Mujeres en Menopausia is a community health worker delivered intervention. So again, no longer a medical visit, but CHW delivered education and then referrals. So you can see there's a lot of good work to be done, and we've been working on that here at Utah. So a little bit of an overview of where I'd like to take us during our hour today. I'll talk a little bit about the menopausal transition. It sounds like you had some menopause education at the last echo, so I'm excited to build on that. And then I'd like to specifically talk about, well, what do we know in terms of Asian American women? Are there a lot of information or is there a gap for our Pacific Islander women as well? The AANHPI long acronym. And then why integrative health? It sounds like that also came up in the last echo, and we'll talk a bit more about that and really looking at what is the evidence base on several of these interventions. And then to kind of wrap things up, I'll talk about, if you don't feel comfortable providing this care, to whom might you refer or where can you get more training if you're keen? And then talk about some resources. And I'll be sure to leave about 15 minutes at the end for discussion, which I'm really excited about. So what I hear most from women, and if they come into your office and you hear this, please clue into what they're saying right away. They'll say things like, I just don't recognize myself. I don't feel like myself. I feel like I'm losing my mind. And it's important to know it's not only women in their 50s, it can be women in their 40s and sometimes in their 30s. So a little bit of detailed facts for you. So if a woman goes through menopause and she's 40 years old or younger, that's called premature, and it's really related to premature ovarian insufficiency. Early menopause is between 40 to 45 years of age. More average, what's natural menopause is 51 is the average age in the United States, and it's pretty similar worldwide. Surgical menopause is the removal of both ovaries. There can be an iatrogenic menopause, we call it, due to chemotherapy, radiation, or estrogen blockers. But I really want to make very clear that more and more women in recent research are experiencing symptoms even when they're cycling right as rain. So this last bullet point is cited below, and women were surveyed. It was a couple thousand women nationwide who responded. And women in premenopause, so again, they're not in peri, they're not having any hormonal changes, and I'll talk a bit more about that in a moment. But women in premenopause, cycling right as rain, were having symptoms, hot flashes, night sweats, feeling like I'm losing it. So again, if you have women in their 30s talking to you, please listen to them. I know you all do because you're caring and you're here on this echo, but it's pretty stunning what we're seeing clinically, and that's really important to know. It can be symptoms before cycle irregularity. So, a little bit more about staging, the three stages of menopause itself. I'm going to start in the middle of the slide, which is what we're most familiar with, menopause. So, that, of course, is amenorrhea, 12 months or more, no periods. We only know that in the rearview mirror after a woman has had no periods for a year. That's when, from there moving forward, she's postmenopausal until death. Before that, this is the key time 8 to 10 years on average, where hormones are variable, symptoms are variable, and it's this time of variability where all heck breaks loose, so to speak, and where women most typically are symptomatic. And it's really key for you to note that this is so much more than hot flashes. That's what we tend to think of. And we often think, oh, a woman's 50, hot flashes. Again, it can be 40s or even 30s. But again, it's so much more than hot flashes. The vasomotor symptoms do include hot flashes, night sweats. What's not on the slide, palpitations and a sense of anxiety. It's this vasomotor event where we're sympathetically driven. And women just often will say, my gosh, am I having a heart attack? And of course, if she might be, she needs to go have that checked out anyway. But many women present to the urgent care or to the emergency and they're not having a heart attack, they're having a vasomotor event. But also, what can happen are these mood swings. One of my patients said, gosh, I feel like I have PMS, but it doesn't stop. It's been for months, where there can be irritability and crying jacks. And of course, this is where we really get into behavioral health territory. It's also common for women to experience weight gain. A pound or two on average per year is not uncommon, and brain fog. What's also not on this slide is sleep, because of course, if women are having night sweats, sleep is interrupted. And if we can't sleep well, then it's really typical to feel like, not ourselves the next day. We might have irritable or volatile moods, as well as brain fog because we're not sleeping well. So those are the identified symptom cluster during this time of life. Now, I find this slide to be worth its weight in gold because the visual is really helpful. I even use it in my clinical practice. So in premenopause, again, women are cycling right as rain, unless they aren't, if they have PCOS or something else. But talking about kind of average, typical premenopause, this is 6 cycles. And you can see, even though there's hormonal variability, it's the same variability. Our body knows what to expect. Perimenopause, again, that's that time 8 to 10 years before the final menstrual period when all heck breaks loose. And this shows it's not only estrogen, but also progesterone, FSH, and LH are variable. It's not this beautiful linear decrease of estrogen. Our body could handle that. But what happens, it's this delta, it's this change from day to day, month to month that really sets a woman's body on edge and can make us highly symptomatic. And postmenopause is important to let your patients know about. Eventually, she's going to get there where it's so nice. Hormones are stable. There's not this variability and volatility, but it takes a while to get there. And
We
one of the
have an excellent,
punchlines,
oh, we have an
please
excellent
go
question.
ahead.
Sorry to interrupt.
Yeah,
How do you know if you're in pre or peri if you are taking birth control? And
absolutely. So, a couple of things. Labs typically are not drawn to determine menopausal stage. It's really by menstrual data. And as you say, if you're taking birth control, like it's forcing those cycles. You can look at LH, that's kind of creeping up over time, as is FSH. So that's something to look at if you really want to be able to determine with certainty. If she's in late peri, then it can be certain. If she's early, it's not going to give us any information. But I think the main thing is to treat the symptoms, really to be sure that the symptoms are managed, especially vasomotor symptoms. And I have a slide about that later because there's some disturbing correlations, some independently associated aspects about vasomotor and other diseases. But you're right, it's tough to stage when she's on birth control pills. And again, perimenopause, that's when we tend to see the symptom cluster the worst. But again, some premenopause, you might see that, and some post, you might as well. So I mentioned it's so much more than vasomotor symptoms. Here's a long laundry list of common symptoms. Yeah, burning ears, body odor, facial hair, It's commonly, I think, known in terms of vaginal tissue thinning. It's not actually dry, it's thinning. Painful sex, osteoporosis. It's a long laundry list again, and these are common symptoms. So when your patients come and say, "Oh gosh, I just have, my itchy skin," it could be related to her perimenopause, and just to validate that, and then of course help her sort out some reasonable treatments for these symptoms. But again, to say the third, and it won't be the last time, it's so much more than vasomotor symptoms. But to go into a little more detail about the vasomotor symptoms that I did mention briefly, those palpitations and sense of anxiety are really important to keep in mind because they can trip up women and clinicians. Of course, if there's any risk of heart disease, if there's a history of heart disease, that needs to be ruled out. But, 9 times out of 10, it's this vasomotor event. And the thing that's disturbing is the duration of years, and again, we're not talking days or weeks or months, years that women on average experience vasomotor symptoms vary by race and ethnicity. So you see here on the right-hand side, African American women on average 10 years. It's all more than double the average duration for Japanese and Chinese American women. You'll also notice there, I'm sorry to say, Asian American Pacific Islander women are not on the list. And we're going to talk about that some more in a minute. But to talk more about this, frankly, what I want to say, very disturbing trend that we need to learn more about is that there's literature showing these vasomotor events are independently predictive. There's correlation data, not causation. I don't want anyone to worry. It's not like a woman is going to have these diseases, but there's more for us to learn scientifically because these independent correlations between vasomotor disease symptoms, heart disease, number one killer of women, Alzheimer's disease, which of course is much more prevalent among women compared to men, and osteoporosis, likewise, many more women than men. So we really need to help our women feel better while they're having these vasomotor events. And then also, this is a perfect time of life to educate our patients or our clients in terms of good lifestyle. I think that was mentioned earlier. We all need to eat well and to exercise and to have happiness and joy in our lives. But there's a lot of reason to keep good care of our heart and prevention of cardiometabolic disease during this time of life as well. So let's think more and learn more about Asian American and Native Hawaiians and Pacific Islander women. What's the literature? What's known about Pacific Islander women's experiences? Well, one lovely study that was conducted in Hilo, and I'm sorry if I'm saying that wrong, but it looked to me like Hilo, Hawaii. This
Hilo,
lovely study, what is it?
Hilo.
Hilo, thank you. See, Hilo. They interviewed 185 women who were across the age range of 45 to 55. They were also staged between pre, peri, and postmenopause. One unfortunate thing about the study, they did not classify race and ethnicity clearly. Around a quarter of the sample was mixed ethnicity, but they didn't describe it very well. I put on the bottom right, specifically the ethnic categories they had were European American, Japanese, mixed, and others. So that's a limitation of the study. But the majority of women grew up in Hawaii. And what's interesting is that if you look at pre compared to peri, so again, pre cycling right as rain, peri going through that time of variability, symptoms increase notably, and the little stars on the far right indicate it's statistically significant. So there's a real difference between pre to perimenopause. And likewise, I want to draw your attention to the night sweats, hot flashes, irritability, mood swings, pretty consistent from peri to post. So the good news that I mentioned earlier in terms of those stable hormones postmenopause, the bad news is it doesn't mean cessation of symptoms. So we still need to be mindful and to treat those symptoms, and they're very commonly experienced in postmenopause. Here's a disturbing fact. 11 to 15% of women who are 70 years old, still having vasomotor symptoms. That's wrong. We can do better, right? It's so disturbing, especially when I mentioned that independent correlations and relationships. We just, it means the body's cranked up, right? It's the sympathetic driven experience that we need to calm and to support. So again, the Gila women study their results. What's interesting is premenopausal women felt anxious. So like, oh no, what's going to happen? I just don't really know. But whereas women who'd gone through the transition, they were definitely more affirming in terms of their attitudes about this new cycle of life, new time of life. And a real dominant theme was this, like, well, who am I now that I'm not cycling anymore? Like, I don't have to worry about pregnancy, but more than that, who am I now? What's my identity? Perry, again, the women going through the transition and post, their attitudes were not biomedically oriented. I think they got to the other side of it, so to speak. And this was lovely. I have a direct quote here that local cultural and island lifestyle may provide a positive atmosphere for women going through menopause. I mentioned briefly before folks had logged on, I unfortunately have not had the good opportunity to come to Hawaii yet, but I know I've heard about island lifestyle, island life, and I think that's very good for everyone. So, another key study, this is a scoping review just published. It's a little small for me to see. I think it was just last year. Yes, 2023. So, a scoping review, in case it's unfamiliar jargon, it's where you cast a wide net. You're looking for scientific literature, gray literature, newspaper articles, anything like what in the world has been written on the topic of racially and ethnically minoritized women who experience mental illnesses with relationship to the menopause transition. So that wide net, they netted over 800 articles, by looking at their inclusion criteria, exclusion criteria. 65 articles met the criteria for their review, and they have a really terrific paper that's in detail about minoritized women and their experiences of the menopause transition. You're going to be happy to see it did include Asian and Pacific Islander women. With that, they actually said, what do you know? The last bullet point there, most studies did not include actually Native American and Pacific Islander women. So they couldn't really add much to our knowledge base because it just isn't there in the literature. So after I found this paper, I did some more searching, and I'm happy to say my very own wonderful dissertation chair and committee member, Doctors Nancy Fugate Woods and Ellen Mitchell, at the University of Washington, they have 4 papers down into the minutia of the findings. They do have some information in terms of Pacific Islander experience, but this longitudinal data set is over 30 years, following women month by month, quarter by quarter, year by year, what their symptoms were. It's a beautiful data set, and there's a little bit of information there. What breaks my heart to say is the SWAN study. This is our guiding light, our very, proud study in the United States to try to learn about women across the nation with a particular eye on BIPOC women. But I'm really, really, really sad to say the I in BIPOC, there's no Indigenous women in the SWAN study, and there's also no Alaska Native women. No Pacific Islander women in this study. So again, our guiding light of minoritized women, we've not included several important groups of women in the SWAN study. To just add emphasis to my point, this has been conducted since 1995. They've had 17 visits, and they did include Pacific Islander women. So all that is to say, I know the literature very deeply on Native American women, having been engaged for the last 3 years working with Indigenous women here in the state of Utah. They're not in the SWAN study, and it's one of the many times we just don't have enough scientific evidence. And I do think the same conclusion can be reached here in terms of Pacific Islander women. And again, I am sorry to be the bearer of bad news. So, some clinical points I want to make in case they're useful, just kind of summing up sort of the nuts and bolts, this overview of menopause and the menopausal transition. The age at changing from one stage to another really matters because premature menopause is associated with greater risks of heart disease, for example. Early menopause, same thing. It's most common to be going through and to arrived at menopause at the early 50s. That's average in the US and worldwide. But to say one more time, in case folks joined late, many women who are cycling right as rain, they're premenopausal, are presenting with symptoms. So please listen to your patients. I know you all do because you're here taking extra time to attend echoes. But this is essential because the symptoms might present before they anticipate they will, or clinicians as well. And then lastly, as you heard me say 4 times, this is the 5th, it's so much more than hot flashes and night sweats. Pain, sleep, mood, cognition, vasomotor. That's the symptom cluster that's identified. So I looked on the Menopause Society website. I highly recommend the website if folks want to learn more. And I thought, well, how many menopause certified providers are there in the areas of my audience today? And so there's 14 in Hawaii, and sadly, no providers, Guam, Samoa, American Samoa, and the Mariana Islands were not even an option to search. So there's 14 folks who are menopause certified in Hawaii. But there's a lot you can do to help yourself to learn and grow as a clinician. The Menopause Society website, and I don't gain anything from promoting them. I'm a member, but just as a professional member. But it's a good website. It's reliable. They have position statements. They have slides that you can access, practice pearls, CEUs, and you can sit for the exam if you'd like. Anyone can become a Menopause Society certified practitioner, including non-prescribing providers. There's a couple social workers that I know. I myself am an acupuncturist. I'm sitting for the exam soon. So anyone can grow and learn and become certified. It's not only for prescribing providers. And of course, conferences are a lot of fun. If you'd like to come in the future, you can go all the way across the continental US and go to Florida next year or closer to home in San Diego in 2026. But there's the website, and it's again a great resource for more information. So now we're going to dive into the main thrust of my topic today, which is integrative health. What is it and why do we care? So these are just a couple models of integrative health. On the left is NIH, the Division of Integrative Health, the NCCIH, funds research on mind-body practices, natural products. Think of acupuncture, chiropractic, massage therapy, herbal medicine, supplements. And then this wheel on the right is the VA's model, and they have this terrific model of whole person health, and they really think about what does the veteran want? What are their needs? And how can we move from there? Including access to, they have acupuncturists in the VA system, massage therapy, so on and so forth. So those are some definitions. But again, why do we care about integrative health? And one reason is that women care about and want to access and do access integrative health therapeutics. In one study, about a quarter of menopausal women were using complementary, and I'll mention too, complementary and alternative are old terms. It's pretty othering, frankly. And so integrative health is a more current term. It's a little more inclusive. So women are accessing these interventions, about a quarter of them in this one study. And a majority of those women do believe that integrative interventions are effective. One problem, of course, is access. A lot of times our health insurance coverage won't cover acupuncture, massage therapy, chiropractic. So it can be really challenging for many to access those services because they're also not widely available in healthcare systems. Unless you're in the VA, then you're in luck. But you have to be a veteran and have served for that or be a family member. So again, in working with midlife women here in Utah, one of the first listening sessions, we first just met, like, what's happening? What are you interested in? Happily, we had women from many communities represented in our community advisory board. And so we said, what are you interested in? And they said, yes, we really want natural approaches to menopause. Many were leaders in their own community. We had leaders from actually Pacific Islander community. You'll be very happy to hear. Native American, Hispanic, refugee community. Who am I forgetting? Oh, Black as well. So it was a very diverse group of women. And they said, yeah, in our communities, women are using natural medicine. They're using herbs. We want to learn more about what's safe and what's reasonable to use. And so in that work, as I mentioned briefly at my intro, we've developed Menogap for anyone and everyone with health insurance. We've adapted it with and for Indigenous women, naming that waning, they named it Waning Moon. That's nurse delivered, and then adapting it with and for Latina, Hispanic women. That's a community health worker delivered intervention. Actually, that's old. Sin Reglas, we tried to name it that, but it's Mujeres en Menopausia. So I'm going to talk about the literature. I'm going to have to go a little fast, and I'm sorry about that. But if people are interested, I'm happy to make the slides available later. So acupuncture therapy is very well evidenced for a good number of concerns midlife women are experiencing. So I always start at the top of the evidence pyramid. If we've got systematic review, meta-analysis, of course, moving down from there. When it comes to vasomotor symptoms, happily, we're at the top of the pyramid. There's very clear and robust evidence. Acupuncture is very effective for vasomotor symptoms, hot flashes, night sweats, palpitations, anxiety. The one caveat is that, long story short, a lot of rubbish research has been conducted where acupuncture has been compared to sham acupuncture. The rubbish part of it, the part that doesn't work scientifically, is that sham acupuncture is not inert. So it's not like a sugar pill in a drug study. So it's like full dose of acupuncture compared to half dose of acupuncture. Of course, there's smaller effect sizes. So that's what you'll see in the literature. And actually, NIH does not support, they don't fund research proposals comparing for RCTs of acupuncture. They will not fund sham acupuncture anymore because it's just not effective, proper control. What's interesting is that acupuncture is well evidenced for low back pain, osteoarthritis, and osteoporosis. So it's worth considering there as well. The evidence is like the biggest mountain you can imagine. The evidence on chronic low back pain is so robust. Medicaid and Medicare will pay for acupuncture for chronic low back pain. We're hoping to see other conditions added. Right now, it's only that one. It's a covered benefit with most insurance plans, and the ACP, the American College of Physicians, lists acupuncture as a first-line intervention for acute, subacute, and chronic pain. So across types of pain, acute, subacute, and chronic. Happily, acupuncture reduces pain, increases function, improves quality of life. It's really worth considering. What's interesting, you can even needle the ear, and there's evidence indicating auricular or ear acupuncture improves or decreases low back pain. Here's that guideline that I mentioned briefly.
And
The
you said
evidence on, oh,
oh,
please.
no, keep going. I'll ask after.
Okay. The evidence on osteoarthritis or OA is robust as well. That's in the American College of Rheumatology Arthritis Foundation guidelines. So 8 weeks of acupuncture. It's not like you have to go forever, but after 8 weeks, definitely reduce the OA pain, and the results persisted for 6 months later. No more acupuncture was received after those 8 weeks. So it's really worth considering for your patients with OA. I should mention one thing I didn't highlight. I said how pain is a part of that symptom cluster, but I can't tell you how many patients and even colleagues have said, wait, pain is a thing during menopause? Oh, yes, pain is a thing. Increase or worsening during peri and post. So please keep pain in mind for your female patients. Here's a trial, quite interesting. They looked at laser acupuncture, so just shining a laser on the acupoints, combined with calcium and vitamin D with fluoride. Bone mineral density improved and pain decreased as well. So that's something to consider in terms of our patients with osteoporosis. There was a massive review of almost 300 studies of acupuncture, really showing some interesting mechanisms of action in terms of how acupuncture might help our bone density. So it's worth considering there as well. But like I said, not everybody can get in for acupuncture with an acupuncturist. So acupressure is something that might be worth considering. It's something they could learn from an acupuncturist or learn if they find the information online, perhaps. But acupressure is simply just pressing those acupoints. It doesn't have to be a long amount of pressure, 1 to 3 minutes per location. And it's something that I include in Menogap, and I'm seeing really good results with that. So here's an interesting group of points that are demonstrated to improve insomnia. So top of the head, I'll not go through all the points, but any acupuncturist will know these points. Point on the bottom of the foot is very grounding. So this is a terrific, it can just be something we could even teach our patients before bed, a little self-care routine. That's, again, evidence to improve insomnia. Osteoarthritis, again, important topic for this group of women. And this is interesting. It was a study of self-acupressure for knee osteoarthritis. And check out those points. All those little dots are the arrows pointing to parts of the body. No acupressure on the knees, but it improved knee pain. So it's a very interesting example of the importance of acupuncture theory and how acupoints are not only massaging the local area, basically, to have efficacy and to show that improvement.
Quick
Chronic
question.
low. Yeah, please.
So Diane asked about the pain. It's not
Mhm.
just cramps, it's actually pain everywhere, right?
Yeah, you name it, from migraine, fibromyalgia, osteoarthritis, just generalized muscle pain, like I'm just achy. What's interesting is one of my menopause collaborators here, she's a menopause certified physician. She sees most often in clinic thumb pain, and it's probably we're all on our phones too much, But I think overuse combined with changing hormones, we see a lot of thumb pain. So pick a
I've got
pain.
that. I've got that. The phantom thumb pain.
Phantom
Yeah.
thumb pain. Try acupuncture. I've needled that a lot. It's typically quite
And
helpful.
and so the question I was going to ask you before was, how
Yeah,
does acupuncture help osteoporosis? And you showed it there. How interesting.
fascinating, right? All those
Yeah.
mechanisms of action.
Oh,
Yeah.
frozen shoulder is often common, Amy says.
Yes. There's a saying in Japan, it's like the 50-year-old woman's shoulder. I don't know exactly the saying, but we get there and we're carrying the burden, however that is in our individual lives of work, family, and so much responsibility. And or I think it's clinically from not enough exercise and local use and just healthy use of our shoulders. And whether it's rotator cuff or other concerns, if it's not severe, acupuncture is worth considering for that as well. Yeah, great questions. Thank you. So chronic low back pain, again, some acupoints shown on the far right in the lumbar area, but back of the knee, back of the calf, buttock, those are the point prescriptions that were used in the study that did show improvement in back pain with acupressure. Acupressure for memory and cognition, I cannot tell you how many women complain of, not complain, they report, they experience cognition concerns, foggy brain, all of that. And so here's some terrific acupoints, top of the head, let's see, front of the hairline, back of the occiput that improve memory and cognition. So mindfulness-based stress reduction, interestingly, has been studied to the moon for menopause-related concerns. There's a dozen studies of MBSR, definitely worth considering. So that's something you could point your patient to. There's so many free resources, even a YouTube video. If they want to try MBSR, they can also take a class. It's 8 weekly sessions typically. So that's worth considering as well. And they had improved hot flashes, quality of life, sleep quality, anxiety, and stress. So that covers almost all the major bases, right? Hypnosis is likely as similarly well evidenced. Not a dozen studies, but here's one that I cite. I personally find it hard to find hypnotherapists, so it's a little bit tricky to refer out for that. But if you know a good hypnotherapist, that's worth considering as well, and a very safe intervention. So I know there were a lot of comments at the beginning in terms of different herbal therapies that you've heard about. A couple quick notes in terms of FDA. Unfortunately, the FDA does not review each herbal supplement and each any kind of vitamin or supplement. There is oversight, but it's not like with medications, pharmaceuticals, where they have to provide safety data. That is not the case with dietary supplements. But what you can take note of is that they track if there's any claims of problems in terms of health problems, and they do track in terms of nutrient claims and things like that. But the part you can take heart in is to advise your clients or patients to look for a supplement with that USP logo. That's the US Pharmacopoeia. That means that what's in the bottle, what they say is there, is actually there. There's not harmful levels of contaminants. It's basically an indicator of like the good housekeeping stamp of approval. It's the good manufacturing practice, the GMP. So that's something you can note when you're talking with your clients or patients about supplements if you do. Um, Key things to know in terms of tofu was mentioned. We talked briefly about black cohosh and red clover. Those are all phytoestrogens. So phyto, of course, means plant. They're plant-like acting, they're plant acting like an estrogen in the body. What's interesting is phytoestrogens actually bind to those estrogen receptors, just not as consistently, not as effectively as our endogenous estrogens, but they do the same thing. What's good to know is, very much in Asian cultures, it's common to have tofu or soy, little amounts, through the day. We tend to overdo things, at least in mainland US, where I'm having soy yogurt and soy milk and all this processed soy. That's not really the traditional way, but typically, if you're ingesting phytoestrogens in food grade quantities, you're not likely to hurt yourself unless you have an allergy. Supplements, of course, people need to see a provider first, but as we know, our patients are taking all kinds of things that are available from Amazon. But some common sources of phytoestrogens are at the bottom there: soy, black cohosh, red clover, carrots, coffee, oranges, and tea, very interestingly. Coffee, however, is often a promoter of vasomotor symptoms, though, so that might be something that women want to take care about. Long story short, there's a very important concern about soy isoflavones, which are phytoestrogens, and what about breast cancer risk? What about overdoing this estrogen input in the body? And long story short, there's some very high level evidence, including over 11,000 women. Actually, women even taking phytoestrogens after cancer diagnosis statistically significantly reduced their recurrence and improved survival. So the really recent literature indicates safety regarding phytoestrogens. But of course, if any patient has a concern, she should talk to her provider, either you or whoever that is, or of course, an oncologist. Black cohosh is the most common supplement that I see women taking, that women ask me about. It's been used traditionally here on the mainland continental US for, I think, millennia. We only have data for the last couple hundred years, but it was used by indigenous women. It's been used in China. I'm a practitioner of Chinese herbal medicine for sure for millennia. So black cohosh is worth considering. It's quite safe when taken up to a year. Really, it's important. Any supplement, just watch out for GI upset is the main thing, and liver concerns. If your patient has a history of liver poor function, liver panel isn't good, they should not be taking supplements willy-nilly. That's very, very important. But here in one study, black cohosh actually outperformed Prozac in terms of supporting hot flashes and night sweats. SSRIs are prescribed. I didn't have time for all of the medical stuff, but SSRIs are actually prescribed for vasomotor symptoms. So then, why were they talking about vasomotor and Prozac? These are some reputable brands that are commonly seen in the, Walgreens or whatever drugstore. Costco carries Estroven on the far left even. Red clover is another phytoestrogen. Again, similar safety, similar side effect concerns. Additional concern to think about is genitourinary syndrome of menopause. I'm sorry I didn't spell that out, GSM. That's the vaginal tissues thinning, increased urinary tract infections concern, increased bacterial vaginosis concern, yeast infections. Basically, down there is not feeling well, and it's because estrogen affects those tissues. What's interesting, similar tissues are what we have in our bodies, both for our vaginal tissues as well as urinary bladder tissues. So that explains why a topical vaginal cream, a topical estrogen, you can also use phytoestrogens that support both vaginal tissues and urinary bladder tissues because it's the same tissue. Ginkgo is used traditionally to support mental function. It's been tested recently. So that's one supplement folks might consider if they're having that foggy brain, that kind of concern. Yoga is evidence to improve memory and cognition. Anyone who's been to a yoga class, you know what that is. Like you're learning all these neat poses and paying attention to how your body's feeling in the poses. It's terrific all the way around. And a pretty exciting review of 12 studies indicated improved executive function, attention, processing speed. So it's really nice to see that rigorous science that's a little more than my airy-fairy description of yoga and our perceptions of the body. Again, yoga is something that women can think about daytime to invigorate and support their energy. And that's something they can think about at nighttime to support quieting down and good quality sleep. So I know I've only got a couple minutes and I've been racing. Sorry about that, but there's a lot of good material to cover. So if you're feeling like what you're hearing from your patient or client is totally out of your wheelhouse, again, you can think about referring. I looked up the Hawaii website as DCCA. If you want to try to find a provider who's licensed, and I did look up the acupuncture information there. Happily, they've completed thousands of hours of training, and they'll have the national board certification as well as state of Hawaii certification as well. Typically, acupuncturists, chiropractors, massage therapists are licensed at the same and with the same bodies that license physicians, nurse practitioners, PAs, psychotherapists, etc. And then, of course, you can talk to leadership if you're in a health system. Can you bring integrative health providers? Typically, there's some robust evidence. Acupuncture is very cheap compared to a lot of these interventions, as is massage therapy and chiropractic. And the most delightful thing I will say that I see in practice is that, say, if a woman comes in and she's like, I'm having hot flashes and night sweats. I can't sleep. I feel like I'm losing my mind. I'm not providing acupuncture for one of those symptoms. I diagnose and treat by assessing the whole person. And what's so rewarding, most patients come back over a period of a couple, 3, 4, 5 sessions and say, Lisa, I feel so much better. Like I can quit this job I've hated for so long. I finally have the energy to like go to this next step. Or Lisa, we didn't even talk about my allergies. How did those get better? Well, it's, the whole system improving itself with this input of acupuncture therapy. So it's really something to consider. And those are some easy referral resources for you. Also, of course, if you have patients or clients coming in, they're like, oh, what about this herb? I'm taking this medication. There's some really good resources online that you can check for herb drug interactions if that's something that you have time to do, or maybe kind of ask for an MA or some help with. So with that, I'm going to take a breath and ask if there's any questions. I'm happy to chat.
There's an excellent comment here from Amy. My understanding is that menopausal hormonal changes dry out our bodies in general, including the fluid in our joints that need to function well. The fluid that our
Mhm.
joints need to function well.
Yeah, absolutely. It's an interesting phenomenon. So dry out is absolutely what women will mention. My eyes are dry, my skin is dry, my hair is dry. Vaginally, I feel dry. Maybe they don't feel that per se in their joints, but it could be that same sort of issue. One very easy way to explain all of this is we have estrogen receptors literally throughout the body. So when there's variability in estrogen, endogenous estrogen, and overall, of course, it's decreasing, those estrogen receptors are just not being treated the way that they used to. And the symptoms can be, again, whole person for sure.
Are there other questions? Does anyone have a case or case follow-up? Can you go back a few? Oh, sorry, you're not sharing anymore. But
Oh, I'm happy to.
the one that the herb that I forgot the name of from last week was right there at the bottom of one of your slides. There it is. Just
Oh, genistein?
yeah,
Yeah,
Genesis.
yeah, that helps with painful intercourse. It's been studied for that.
Oh, I
Hmm.
think was that the one last week? Amy says, can we also see the herb slide that listed all?
Oh, sure. Let's see what listed all of them. Maybe, no, that's just different medications. This one has different foods, but not so much herbs. Not sure that I had one actually where they're all listed. But the long and the short of it is, most of these are phytoestrogens. Most of them are going to be safe for most folks. One thing that's interesting in terms of just coming back to the genistein question, so vaginal estrogen improves the cytology. So those little vaginal cells poof back up basically, and there's more normal cytology in the vaginal tissues. But some women either don't want to take vaginal estrogen or it's not indicated for them. And what's interesting is that this phenylvaginal actually shows those similar vaginal cellular changes and improvement. So again, that's something that women can consider. And red clover oil, again, has those same cytological changes. So it's pretty interesting science when you come down to it. Oh, sorry, I just realized I put the video on top of the slide. Sorry if you
Oh no,
couldn't
no,
see very well.
you're good. Did you have a slide that said herbal therapies?
Let me go back.
I don't remember either.
Because here I just go through FDA stuff. I didn't really have a slide that listed, oh,
Oh,
this, here we go. I
okay.
forgot about this one. I focused on the cute picture. Yeah.
Oh yeah, that's right. I like the pictures.
Hmm.
And then Joanna says for latrogenic menopause for women between 40 and 45 years old of
Yep.
age, how long would you say before they are considered postmenopausal?
It's then in terms of iatrogenic, the menses stopped and we know they're not going to come back with chemo, radiation, so on and so forth. So it's really then. Um, and then typically it's a brutal menopause experience. I don't know. I'm sure there are women who miraculously are just feeling fine, but most women, it's very intense hot flashes and night sweats. In fact, we wrote a grant, this was with colleagues in Indiana, to adapt Menogap with and for African American women with breast cancer because the literature shows even though more white women are diagnosed than black women, more black women die. A key part of the problem is that black women were not staying on their aromatase inhibitors because the vasomotor symptoms are so bad. So that's the real key thing. When there's an iatrogenic menopause, most often it's oncology. We really need to empower our patients and do everything we can to help them feel as comfortable as they can and stay on their medicine if that's a part of their clinical picture. So I know that wasn't exactly the question, but I think it's interesting to know.
Those statistics are true also for Native Hawaiian women suffering from cancer.
Not surprised.
Fewer diagnoses, more death.
More death. Yeah. Do you know if it's that same phenomenon in terms of aromatase inhibitors not being continued, or is it across types of cancer and
I
not?
don't know. I think it's late stage diagnosis for one.
Oh, yeah, that's a
Yeah.
part of it, I think.
Yeah. And
Yeah,
yeah, I'm not sure about the aromatase inhibitors.
yeah.
Um, so also from the iatric, which iatrogenic, sorry, which I read with as starting with the L. For on that question, would you say to stay on HRT or I mean, I guess aren't they given HRT right away after the surgery?
No, it definitely depends on the type of cancer, and stop sharing so then we can just
That
see
makes
each other.
sense. Yeah.
Yeah. But if it's a situation where, for sure, if it's estrogen receptor positive, they're not going to be able to take menopause hormone therapy. And then they're typically just like left to suffer. And unfortunately, yeah, there's real indication for safety for some of these interventions for women with cancer. But it's to my understanding, what I see here in Utah, it's not a part of standard clinical practice, unfortunately, to include integrative therapeutics, even mindfulness, even yoga, even, it doesn't need to be phytoestrogens if people are worried about that. So there's a lot that can really be done to better manage these symptoms for sure.
Are you familiar with the book, The Wisdom of Menopause? I now have it on my library wait list.
Yes, I've not read it, but I know Christiane Northrup's work. I've read her other books, in many years past. So I think she's a terrific author, and I'm sure it's a good resource.
How do you determine what stage a woman is in if she's had a hysterectomy, but ovaries remain and no longer has periods?
Right. Yeah, it would be the date of the hysterectomy. So that's again that iatrogenic, like here we are. Most women, actually, there's variable data on that. It's a split. Some women have that partial hysterectomy and are asymptomatic. Some women, even with ovaries intact, are symptomatic. So really, it's something to take note of and treat according to what you see.
Oh, and Summer reminds me that Dong Quai was the herb mentioned last week.
Oh, I'm familiar with that. We use that in Chinese herbal medicine. That's an amazing herbal supplement and definitely phytoestrogen for sure.
And can you repeat the name of the author about the books you recommended?
Um,
I know there's a website there. Was it?
yes, I mentioned the Menopause Society. I can pull that up and put that in the chat. Authors, I hadn't really pulled that together. Mary Claire Haver's been in the news lately. She has books. She's got the Galvanstein. Something. It's a town in Texas. That's where she lives. The Galvanstein diet, and then another book. She's also controversial. She's really, I think, more on the hormone pellet side of things. The Menopause Society is not. So there's some challenges there in terms of sorting out, resources that people are comfortable with. Just going to pull up the Menopause Society real quick.
All right.
I
Well,
will.
thank you. Go ahead.
Oh, sorry. I was going to say, I will say that hormone place replacement therapy, when it's prescribed, that's, de rigueur, that's standard. Everybody's used to that. There are actually a few menopause hormone therapies that one is yam-based for progesterone, micronized progesterone is. So there's some natural hormone therapy that any, menopause provider will provide. Um, There's something else I was going to say. Oh, menopause hormone therapy is about a third or a quarter of the dose of birth control. So it's a much lower dose for maintenance. It's a completely different kettle of fish if women are worried about hormone therapy. Again, menopause hormone therapy is about a third to a quarter of the dose of birth control. That being said, it doesn't provide birth control. So if a woman's in perimenopause, she really needs to suss that out with her provider. Pellets are another thing. So what I see here in Utah, and I think it's across the states and regions, and I see it internationally as well. Um, Come on in, you know where you're suffering. This is all cash-based practice. We're going to do blood work, which again is not indicated. It's just not good science during perimenopause. Post, that's another thing. And then, here's $1,000 pellet therapy, and they inject these pellets under the skin. We've had patients in Menogap with clitoral megaly because of too high of testosterone. It is not, I just feel like it's a real predatory approach, and it's disturbing to see. And it's again a cash-based high amount of money being charged. So there's concerns there. I'm sure some providers are doing right by their patients and practicing safely, but it really is it's a challenge.
And there's a couple books in the chat there. The Menopause Reset. Get rid of your symptoms and feel like your younger self again. Oh, that sounds good. The
Yeah.
Hormone Shift, balance your body and thrive through midlife and menopause.
I would look for
Very
those. I don't know Doctors Batia and Pell's work, but I'll definitely look at those.